Good. As I was saying, the fat typically has this bubble-like appearance, which you'd expect when you see it on a slide, and then we consider its functions. Your adipose tissue has the job of providing cushioning as a form of insulation, and also energy storage. I mean, that the reason that we have the fat that we have is because it is a way of holding on to a fuel that can be then catabolized and used to make ATP. So energy storage, insulation, and cushioning are the main reasons that we have adipose tissue at all. Now there is also a kind of fat called brown fat that you find in hibernating animals, but also on human infants, that is not there to do any of these other things, but there to actually produce heat. Because when you do utilize it, that is, break it down, it produces more chemical heat than anything else. You don't even get much in the way of ATP out of it. But there we go. Basically, just one form of fat to look for on slides, but with these functions: energy storage, insulation, and cushioning. Then the next one, cartilage. Cartilage is an unusual tissue. It's still connective tissue because you can see the cells are separated from one another by matrix. But the matrix between them doesn't usually look necessarily like it has a lot of fibers in it, right? Which is what you would expect to find in a connective tissue. But that's just because the fibers may be hidden behind an awful lot of other materials, like, for instance, a rubbery set of proteins that are wrapped around the fibers themselves, so as to give the entire tissue a rubbery but solid and a flexible nature. Right? So we got three different kinds of cartilage. All of them are going to have these cells called chondrocytes inside of them. Chondro being the prefix that indicates cartilage and cyte for cell. Right? The way they grow this tissue is kind of neat. The cell, the chondrocyte, starts off and then secretes the matrix around it. And so as a result, since this matrix is relatively hard and solid, it entraps itself inside of its own created matrix. And so the living cell is now physically isolated from the other cells nearby, and for that matter even from the blood. There are no blood vessels inside of cartilage, which is one of the reasons that cartilage is relatively slow to heal. Right? But they surround themselves with matrix until they're trapped in cavities called lacuna. So if you take one of these cells out of the cartilage, there'll be a little fluid-filled space left behind, and that's the lacuna. I think that's Spanish for lake. Once the cells are trapped in their own matrix, we call them chondrocytes. If they're growing the cartilage instead, then we call that a chondroblast. Because remember, the blast means a grower cell of some sort. Cartilage is typically free of blood vessels. Diffusion of nutrients and waste is slow. Chondrocytes have a low rate of metabolism and cell division, and thus cartilage heals slowly. In fact, slower than bone, unfortunately. But here are your three types of cartilage. Hyaline cartilage, clear and glassy, matrix in between the cells, and no really visible fibers. Right? It is the medium toughness cartilage. It does have fibers, but it is both elastic as well as resistant to stretching. Your nose is made up of a lot of this hyaline cartilage. In fact, hyaline cartilage is the most common cartilage in the entire body. Your rib cage, the parts of your rib cage that are made of cartilage, is hyaline cartilage. In fact, most of the stuff that you find around your various joints that help to smooth the action of them, though that's also hyaline cartilage. Right? And so that's what I have down here. Articular cartilage at your articulations, aka your joints. Costal cartilage at your ribs, trachea, larynx, so those are the ones here in your neck. All of that is hyaline cartilage. But medium toughness, medium elasticity. As opposed to elastic cartilage. Under a scope, elastic cartilage cells tend to be a little bit bigger, but like in the hyaline cartilage, they appear to show up in pairs and triples. But now you might be able to see some very skinny fibers in the matrix. And these fibers tend to go in multiple directions, side to side, up and down, back and forth, because here we need something that has a greater quantity of elasticity. So it can't be fiber loaded, otherwise it'd be too tough. And the fibers have to be able to resist pull in all directions, kind of like irregular fibers connected tissue. So elastic cartilage is the most elastic, but the least tough, because it has the least number of proteins in the matrix. And you find some of that stuff out here, ears. Okay. And not only there, but also your epiglottis. It's that little trap door thing that you have going in the back of your throat. So every time that you swallow, your epiglottis folds over the opening to your windpipe so that food doesn't go down it, right? And then springs back up again when you're not swallowing. So we need in those places that need that high level of flexibility. Third type of cartilage is called fibrocartilage. And here, you may note that there's a rather regular appearance to it. The chondrocytes seem to be organized into columns, but even then you still see them somewhat separated into clumps, often pairs and triples. Right? But the space between them is filled with very, very dense, fiber-packed cartilage matrix. Right? So fibrocartilage like this is usually meant to be extremely resistant to stretching, but not terribly elastic. And so some places you're going to find this are areas that have to go under an awful lot of strain every single day. For example, in the intervertebral discs, those are the ones that are in between your spinal bones, your vertebra. And just think about it, they're being crushed every single day by gravity every time that you walk around and your foot impacts the floor. Okay? Then also pubic symphysis, that's one of the ones that's in your pelvis, just in the front, and the menisci of your knees. Now, if anybody's ever heard about a torn meniscus, then you're talking about a big fibrocartilage pad that lies between your femur and your tibia, and if you do damage to it, then that means that your knees, the two bones, don't quite fit as well to one another, because the meniscus is there to help to stabilize the joint. But think about the pressure that must be on your knees every single day, just like your spine. Constant crushing forces from above as your entire weight of your body hits down on your knee when you put weight on it. So fibrocartilage is kind of organized in appearance, has these clumps of cells, often organized into columns, with thick protein-loaded matrix between them that almost looks like regular fibrous connective tissue. So that's fibrocartilage. So most tough, least elastic. Then you have your hyaline cartilage, middle toughness, middle elasticity, but you don't actually see the fibers terribly well. You still see cartilage cells in clumps and triples, pairs and triples. And then you have elastic cartilage, most elastic, least tough. It has irregular fibers running through its matrix, going in multiple directions. But there you go. Those are your three forms of cartilage and places where you can find each of them. Then we get to, let's see, bone. Okay. Bone is our hardest connective tissue, obviously, and under a scope, it always has the same appearance. Things that look like tree rings, clusters of tree rings, in fact. Now, the middle of each one of those is not a bone cell, not an osteocyte. Instead, those big dark circles right there are blood vessels that are running through bone. Bone's a vascular tissue. It's alive, obviously, and if you break it, bone will bleed. And the reason we've got so many blood vessels running through your solid bone is because of all of these little cells that are wrapped around them. So all of those tiny little black hairy caterpillars are the actual osteocytes. And they grew this tissue. Before, these cells were sitting in a more fluid environment, maybe a few protein fibers that they were clinging to. But then, these cells grew a protein matrix first, and then after that they released an enzyme that caused that protein to encrust with calcium crystals. And so as a result, developed these rings of bone. And they spread not outwards, but inwards towards the blood vessel. We'll explain how that happens later. But end result is that you have all of these bone cells that are now trapped in their own matrix, just like the cartilage cells are. And in fact, the little fluid-filled space that they're inside of is called a lacuna. Right? But whenever you're looking at a slide, this is really what you should be expecting. Tree ring-like collections of individual osteocytes wrapped around blood vessels. So I feel it's pretty easy to recognize. Let's see. So bone is also called osseous tissue. You can remember that the prefix OS generally means having to do with bone. Okay? And when you get closer to, let's see, a bone that has, let's see, well, a cutaway through it. Let's see if I can get a good picture of this one. So let's go to this one. Right. Bone tissue. Here we go. Yeah, a shot like this one. Come on, work with me here. No, that's not the one. Try again. There we go. When you get close to a bone organ, you'll find that there's two forms of it. On the superficial surface of all your bones, you have something called compact bone. But deeper inside, you have something called spongy bone. It actually looks like a sponge, lots and lots of little holes, and then bits of solid material that lie between the holes. Those spikes and ridges are called trabeculae. So it looks like a sponge, but if you poke at it with your finger, it's still a hard material. I mean, under a microscope, all of that, spongy or compact, still looks like this. Right? But let's see. Your compact bone appears to have no holes in it, although it does have blood vessels running through it on a microscopic scale. And that's the main hard, rigid component of bone that gives us our structural support. But inside, where there's spongy bone, there you tend to find other tissue filling the space. Like, for instance, down the middle of the shaft of one of these long bones, you'd find yellow marrow, which is the same thing as adipose tissue. It's just fat, so there's fat on the inside of your bones. But here, in the heads of some of your long bones and a number of the other ones, you'll find red marrow, which is where you're going to form red blood cells, and for that matter, white blood cells. And here's one other benefit. By having sections of your bone be lacy and not having as much solid bone material, we're lighter as a result. I think the statistic is if you had all your spongy bone areas filled up with solid bone, we'd all weigh about 30 pounds more, about. So this helps us to stay relatively light without having to give up a lot of structural integrity. The spongy bone is still quite resistant. Right? So compact bone is superficial, spongy bone is deep inside some bones, not necessarily all of them, because some of them are going to have that hollow space that's said filled with yellow marrow. Let's see. Compact bone is arranged in cylinders of tissue that surround central haversian canals. So back up to this. So there's your blood vessel right there. The space that the blood vessel inhabits is called the haversian canal, right? And come back. No, so I didn't want to do that. Hang on. There we go. Okay, so back to this. Back up there. So the haversian canal is the central canal where the blood vessel resides. Then, bone matrix is then deposited in concentric lamella. The lamella are each of these rings. So the rings may not have terribly distinct boundaries, but see that line right there and that one right there? That would make up one lamella, and there's another lamella, and there's another lamella there. There's something about like the word lamination. If something's laminated, it's got various layers and coats of some sort of material on top of it. So these lamella are the rings or coats of bone matrix. Right? They're around each central canal. The central canal and surrounding lamella make up a thing called an osteon. So all this is one osteon, and then here's another osteon over here, and you can see there's another one here and another one here. But one cylindrical unit makes up one osteon. Right? The lacuna that are between the lamella are occupied by your mature bone cells called osteocytes. So that dark object right there is the osteocyte itself. Yeah. Do it again. I need to edit this stuff. Right. So each one of them is a single osteocyte sitting inside of its lacuna, and the way that these cells actually get nutrients is through these radial running lines that you see going between the blood vessel and the lacuna. Those things are called canaliculi, or little canals, and they allow fluid to leave the blood and go towards every single one of these living cells. Right? So when you, say, need to repair bone, these cells aren't going to be doing much. Out on the surfaces of your bones, on the very superficial surface or on the deep interior, is where we have osteoblasts, cells that will grow bone. And they will help with the repair process. But once an osteoblast surrounds itself with its own matrix, then it's pretty much stuck there permanently. And so these bone cells may be with you for decades of time, and still being fed by the blood vessel inside the haversian canal, and then the fluids run through these radial running canaliculi. Now, on the outside of the bone, you have a special layer of fibrous connective tissue that's called the periosteum. Right? The prefix peri does mean next to. Right? So periosteum is next to the bone. Right? And this periosteum is like a sleeve around your arm. Right? Fibrous connective tissue that helps to encapsulate the entire bone. And it's in that periosteum that you're going to find the osteoblasts that you need to repair this bone should it get damaged. Okay? So the bone as a whole is covered with a fibrous periosteum, and let's see, 2/3 of the weight of the bone is calcium salts deposited around collagen fibers. So all that solid stuff that you were seeing, you may not be able to see the fibers, but they are there. They're just embedded within the calcium matrix. Okay? But I think that's everything we need for the bone. The next type of connective tissue, after fibrous connective tissue, and then adipose tissue, and then cartilage and bone, our last one is blood. Right? So we got a blood shot down here. Blood is pretty easy to recognize once you know what it is you're looking for. Inside of blood, you have more than just red blood cells. You also have white blood cells. It is a fluid connective tissue, which doesn't have much in the way of fibrous proteins between the cells. Instead, you have a liquid blood plasma. Now, there are some proteins there. Blood plasma is kind of sticky and thick. It's thicker than water, and that's because of the globular proteins that are present as opposed to fibrous ones. Okay? But even so, it has so few proteins in its matrix that it's still a liquid form. Okay? And what's your primary function of blood? Transport. Carry stuff. The red blood cells, all looking like little pink donuts here, or Cheerios, those are there to carry oxygen, and even a small amount of carbon dioxide. The plasma carries a lot more. In the plasma, between the cells, is where you're going to have most of your nutrients, like carbohydrates and amino acids and fatty acids and minerals and vitamins and so forth, but also waste material, like urea and uric acid, as things made by your tissues that need to be removed from your body, right? Plus hormones and other electrolytes and so on. So there's an awful lot being carried around here. But one of the other functions of your blood is that of immunity. And that's the responsibility of these cells. These are just a couple examples of white blood cells. They're there in a much smaller quantity than the red blood cells are in your entire blood. In fact, I think the statistic is, if in a unit of blood, about 55% of it is plasma, 45% of it is pure cellular material. And most of that 45% are red blood cells, only about 1% are other cells, like white blood cells and platelets. Alright, so the blood can be divided up into these parts. You have the plasma, which is the equivalent of the matrix, and then you have all the cells and cell product, which are called the formed elements, because you formed these things to put into your bloodstream. Okay? And the formed elements are there in a slightly smaller quantity than the blood plasma. Okay? They include your red blood cells, also known as erythrocytes, your white blood cells, called leukocytes, and platelets, like that little thing right there, or those right there, or that one. Those are platelets, which are cell fragments, and sometimes we also call them thrombocytes. Thrombo is a prefix that means having to do with clotting, and that's what platelets are for. Platelets are there to help stop bleeding should you get a wound, but if you don't get a wound, they do nothing. They need to be triggered by a wound. Otherwise, we'd have clots forming spontaneously inside your bloodstream, and that would be bad. Okay? But there you go. That's it for the connective tissues. There's still a couple more tissues to consider, though. Nervous tissue and muscle tissue. So, let me move to a different image. Okay, tissue histology, so nervous next. Alright. Now, nervous tissue consists of neurons and neuroglia, or glial cells. In an image like this one, there's your central neuron. Now, neurons are massive cells, at least at their body there are. They're fibrous projections, their dendrites and their axons. Those can be pretty skinny, but they can also be exceedingly long. For example, a neuron like this may have its cell body positioned somewhere in your spinal cord, maybe even your brain. But its axon, the portion of it that now communicates with other cells, can be as long as your arm or your leg. So that means we're talking about, in some cases, a meter or more in length. But the cell body is still usually going to be positioned somewhere close to your brain or spinal cord, or in those organs themselves. Okay. But take a look at the size of it. That's one cell compared to these other more average-sized neuroglia. And the neuroglial cells make up an awful lot of your brain material. Not as much of the neurons. I mean, the neurons still make up most of the mass of your brain, but the neuroglia are there and outnumber the neurons by about 50 to 1. Okay. The neuron's one job is to send signals, right? To pass electrical information from one region to another. Now, sometimes that region is coming from the body, like your sense of touch, going towards your brain, and then sometimes it's communication within the brain and spinal cord, just going from lobe to lobe to lobe, so that you remember things or bring up connections between things, make associations, essentially. And then some of those neurons are going to send signals from your brain back out towards your body to cause them to respond in some fashion, to move or to secrete. Right? But that's all they do. They send signals. They're so good at it that they've lost some of their functions that other cells normally possess, like, say, feeding themselves or helping to get rid of their own waste material. And that's why we have the neuroglia. They're there to help fortify the neurons and take care of an awful lot of those other maintenance functions. Right? So every neuron has a cell body, also called a soma, S-O-M-A, and every time that you see the word soma, you should be associating that with body or mass of some kind. Right? And then it has the dendrites, which are most of the shorter projections, the shorter projections typically on a neuron that are there to receive information. Electrical signals will be running from these towards the neuron soma. But whatever's the longest projection, right now I'm just assuming that's this one, that's the axon. That will carry an electrical signal away from the soma. So all dendrites carry electrical signals towards the soma. All axons carry signals away from the soma. Yeah. And then the glial cells, the neuroglia, they make up most of the volume of the nervous tissue. They provide physical support, chemical and immune protection, and various housekeeping functions to make sure that your neurons stay alive. Because that's one of the tricks about your nervous system. You're almost never going to get any new neurons after you reach your adult size. There are a couple exceptions, like for instance in your nasal membranes, there are actually neurons that do regenerate, but in your brain and spinal cord, you generally do not get any more. So if they get damaged, then that's a permanent loss. You may hear about anecdotal stories about people who have had full recovery from severe brain trauma. Well, some of that is fiction, and the ones that are not are extremely, extremely rare. Generally, you just don't get your neurons back, which is why they get this protection from all these other neuroglia. Sometimes physical protection, chemical protection, and pathogenic protection, immune protection. But fortunately for us, that's about it. I mean, you don't have to identify things that are particularly strange or unusual looking. Just look for these star-shaped cells, which are your neurons, and that's a stellate form, and then peppered around them, you're going to find all kinds of neuroglia. Now, sometimes the neurons are not going to be quite so obviously star-shaped. Like, for instance, here, that's a neuron, right? And so are these here, here, and here. You just have to kind of look for the little points that extend off of them. That's another, yeah. But as long as you are able to identify a few pointed projections sticking off them, then you'll be in pretty good shape for identifying neurons. Okay. Now here, this is a slice of cerebral tissue. And here, the neurons, you may not be able to see the soma quite so well because there's no nucleus, but look at all those spiky projections coming off of the central mass. It makes them look like lightning bursts. Right? Those are also all neurons. This one is a very squat neuron with many short projections sticking off it, whereas here's a slightly longer one. Okay? But that spiky appearance is typical of your neuron form. All right? And what that leaves now is muscle tissue. So let's see, jump back up. Nervous system, neural tissue, muscle tissue histology. Check. Okay. 3 forms of muscle tissue, all with the same job. And that one job is to get shorter. Muscle cells, when they relax, they can get somewhat longer, but that's not a sort of an intention. It's just physics causing them to relax somewhat. Generally, after you have relaxed a muscle cell, it doesn't push out back to the dimensions that it originally possessed. It got shorter when you stimulated it, and then when you relax it, it gets a little bit longer. So to get it back to its original size, very often you need something else to pull on it in an opposing fashion. And for most of our joints, that means some sort of opposing muscle. Like if I want to bend at the elbow, I use my biceps brachii, it gets shorter and my arm comes up and flexes here at the elbow. But my triceps brachii got longer when I contracted my biceps. And so now when I contract my triceps, then I extended the elbow and my biceps lengthens. So all of our joints are set up with these opposing muscle pairs or antagonistic pairs. And thus, muscle cells then get longer. Now there's other things they'll pull on them too, some of the connective tissues inside of a muscle. There are some elastic fibers, proteins within the muscle cell itself that'll kind of push them back outwards. But for the most part, we have these antagonistic pairs, particularly amongst our skeletal muscle cells. And skeletal muscle cells is what we saw in the last laboratory. So when you get a good close-up look at one of them, like this one here, you can see elongated cells with striations, these short hatch marks that are running across the short axis, and multiple nuclei inside of each cell. So that was the sort of classic type of muscle tissue that we looked at in the last laboratory. Right? But there are two other forms. There's cardiac muscle tissue, which is only found in the heart, and smooth muscle tissue, which is only found in tubular organs other than the heart. And that includes things like, say, your lung vessels, and your blood vessels, and your digestive tract, and your urinary tract, and your reproductive tract. So all those other tubular organs have smooth muscle tissue in their walls. Cardiac muscle only in the heart, and skeletal muscle tissue is attached to your skeleton. And at least one end has to be connected to your bones. Okay? But the job of all of them is to get shorter. Okay? And we'll talk about how they pull that off later on. But let's see. Skeletal muscle tissue, elongated, fibrous cells, has striations, and multiple nuclei. Plus, they also can consider how it's controlled. You can choose to move any skeletal muscle tissue. Back up. You can choose to move any skeletal muscle tissue, so they are under voluntary control. But that doesn't mean that all the control is voluntary. For instance, say the muscle that's here underneath your lungs, the one that allows you to breathe in, that one's called your diaphragm. If you're not thinking about it, it's running on its own because of signals it's receiving from your subconscious brain. Right? So you don't have to think about moving every skeletal muscle, but when you choose to, you can move it, which is why we can hold our breath occasionally. Or, in my case, as I keep on talking at you, I can control my diaphragm so as to create sounds and words. Even when you get a reflex, something strikes you and you have a reflexive action, that is also an involuntary response of skeletal muscle that generally is somewhat difficult to suppress. Now, cardiac muscle. Here's a good shot of some cardiac muscle because it shows one of the really big defining features. Cardiac muscle does have striations. You can just barely see some of the lines running across. The cells, however, are not really long, fibrous ones. They're short, branched cells, so they kind of look like this, right, with more fingers coming out the other side. Right? And each individual cell just has one nucleus. But those branched cells have these lines that seem to demarcate where one cell ends and the next one begins. And those things are called intercalated discs. Right? So right here, that line there, and there, and there, and there, that is what you will want to look for on a slide to determine whether you're looking at cardiac muscle tissue or skeletal muscle tissue. Skeletal muscle tissue, like this stuff, there are none of those extra dark lines helping to mark off one cell from the other one. But in cardiac muscle, you should be able to see dozens of them in and amongst the pieces of the cells. So if you see those intercalated discs, it's got to be cardiac muscle tissue. And the reason it's so dark is because of a place where one muscle cell and another intermesh with one another. And that means there's an awful lot of material that's stopping light passing through, and thus it looks darker. Right? But those intercalated discs, unique to cardiac muscle tissue, and should be the main thing you look for to help establish which one it is. Right? So let's see. Cardiac muscle cells. They're smaller, they have one nucleus, they do have striations, and they have these intercalated discs to help you identify them. And I guess you can ask yourself the question, do cardiac muscle cells work under voluntary or involuntary control? Well, try stopping your heart by thinking about it. Nope, still beating. So yeah, all of your cardiac muscle tissue is under involuntary control. Now, admittedly, you may have heard about people who are able to slow down their heart, through meditation and so forth. Well, yeah, that can be done, but it's not a direct connection. What those people are doing is they are controlling their breathing. And by controlling their breathing voluntarily, they change their blood chemistry. And if you change your blood chemistry, then your heart will respond reflexively to those changes. Right? So by, say, taking deep breaths, you'll be getting rid of more carbon dioxide, and maybe also increasing your oxygen content, and thus your heart doesn't have to pump as hard in order to push that oxygen-loaded blood to your tissues. And so your oxygen demand will be lower. You don't have as much need for a powerful heartbeat. But you didn't choose to slow your heart down. You chose to change your breathing. Okay. And last one, smooth muscle tissue. Smooth muscle tissue, involves, just make sure this is the right stuff. I don't see any intercalated discs. Smooth muscle tissue involve muscle cells that are fusiform in shape, which is they're thick in the middle and then they taper off and get thin at both ends. They have only one nucleus. The cells are relatively short. And they're packed in very closely side by side. So to my mind, it makes me think of a stream that's filled with tadpoles or fish, right? All running in more or less the same direction. So here's some more smooth muscle tissue, shown in running in an upward-downward direction. Here's some smooth muscle like so. And again, more smooth muscle. And one might think, okay, well, how do I know this is smooth muscle and not, say, dense, regular fibrous connective tissue? Well, some of that comes with practice. But generally, you should be looking at a really, really close packing of cells, and their nuclei should be very, very close to one another. Whereas if you had dense, regular fibrous connective tissue, the cells would be very, very sparse and widely spaced away from one another. Okay? But here are the physical features. One smooth muscle cell is short, single nucleus, no striations. And that's the reason it's smooth and not cardiac or skeletal, just the lack of striations. And while they can contract just as well as the others, these generally don't contract as powerfully, but they do have excellent stamina. And have you ever felt your stomach get tired, or your small intestine, or any of those things? Probably not, because these things do have an excellent level of stamina, even though they don't have necessarily a great power of strength, not a lot of contractile force. But then again, your stomach's not lifting weights, it's just moving a slush around on the inside. Right? So what would you think about the control level or control form for this? Voluntary, involuntary? Involuntary. And again, you don't think about making your stomach digest, you just put food into it and off it goes. Same thing for your blood vessels or your urinary tract. You don't really have control over your bladder. It tells you when it needs to go because it chooses to contract thanks to the stimulus of being filled with urine. Okay? But there we go. We finally made it through all of your various tissue types. So once again, from the top, you've got epithelial tissue, lining surfaces. Had three forms of cells, squamous, cuboidal, and columnar, and it had essentially two forms of layering, simple or stratified, with that sort of middle one, pseudostratified, where it looks like it's more than one, but it's really just one. Then you have your connective tissues, which include fibrous connective tissue, then adipose tissue, then cartilage, then bone, and blood. And some of those had their subcategories, like loose and dense fibrous connective tissue, or hyaline cartilage, elastic cartilage, fibrocartilage. And then we have nervous tissue, which is really just made up of two cell types, neurons and neuroglia, and now muscle tissue, three forms: skeletal muscle tissue, cardiac muscle tissue, and smooth muscle tissue. And you should spend some time remembering what are the physical differences between them, as well as what kind of control we have over each. Okay, so that takes care of the histology, and hopefully in the laboratory, if we have it, you will have the chance to see more of these examples on the slides. But this brings us back now to the rest of this chapter, which has to do with how we hold these cells together. Cell junctions, glands, and membranes is what it says in the notes. We've seen that one of the functions of proteins, proteins in the body, is cell adhesion molecules. Well, now we get to see that there's actually more than one form of that. A lot of your cells need to be held together quite firmly, but some cells need to be able to stretch and move at least a little bit between them. And so we have these different kinds of cell junctions. Now the first one at the top here is called a tight junction. Tight junctions almost kind of look in this example like Velcro, where you would have hooks on one side and hooks on the other that grab hold of one another and then don't let go. And that's not entirely untrue. I mean, it's a pretty close approximation of what actually occurs. You have two proteins with active sites that are meant to bind with one another and create a series of hydrogen bonds. But here's one of the important parts of tight junctions. You need to have a lot of them. Generally, if you want two cells to be firmly held together, then you create large regions, like big bands of tight junctions between two cell membranes. So Velcro may actually be more appropriate than initially thought, because on one side you've got thousands of little hooks, and on the other side you have thousands of little cloth loops. Put the two together, and the more surface area you have touching one another that are loaded with these tight junctions, the harder it is to pull those things apart from one another. I often like to think of tight junctions as being like Velcro, or maybe like a zipper. In a zipper, you see there are little teeth that are interconnecting. And can you pass, let's say, water through a zipper? You know, there's some small holes. Admittedly, it's not going to go through very easily just because the holes are tiny. So if you have two cells that are held together with this zipper-like pattern of tight junctions, then there's not going to be a lot of space in between those cells. And thus, not a lot of fluid flow will get between them. Okay, so you see these two sections of the membrane that are just firmly connected. That's due to tight junctions, and that's going to inhibit water flow. So a place where you can find a lot of these, around your skin. Right? Those dead cells that are in the stratum corneum of your skin, the superficial surface, they're held together with tight junctions, and that's one of the reasons that they're inhibiting water's passage out of us and into the environment. Right? But the second type, desmosomes. Desmosomes are these here, and you see how much space there is in between the cells? Here, instead of being like a zipper, two cells are being held together almost as if they were using a button as opposed to a zipper. You have one set of protein fibers on one side attached to this plaque, which is embedded in the plasma membrane, and then you have a similar one on the opposite side. Well, so move that over. Now, this means that there's a little bit of wiggle room between these two cells, and fluid, water, could actually flow between the cells if you wanted them to. This gives us a different form of holding the cells together. They're still connected by these button-like desmosome protein plaques, but there's a little bit of give. You can have fluid flow happening between the cells and the extracellular fluid, but the cells are still firmly together. Whereas if you're using tight junctions, firmly held together, but not allowing fluid flow between, or at least inhibiting it somewhat. And the last one, down here, we have gap junctions. Gap junctions are only going to gently hold two cells together. What they're really most important for doing is allowing fluid flow between the cells. Think of it this way. You have a tunnel in one cell, right? So that stuff could pass from inside to outside. But then on the other cell, you have another tunnel. And now, there we go, there's the opening. Now you have passage between one cell cytoplasm and the next. And so consequently, anything that's in cell 1 can now flow into cell 2, provided it can fit through the holes. This can allow for osmosis to occur faster. It can allow for diffusion to occur faster by helping to facilitate that through these open spaces. We see a lot of gap junctions in cells that are electrically active. Electrically active cells like muscles and neurons, they don't actually have real electricity running through them. They have ions, charged atoms that flow from one cell to the next. And this is the main way that they're going to do it, through these gap junctions, where you just have rings of protein joined with one another, there you go, to allow that passage all the way through, just so long as the particles are the right size and the right shape. Okay? But that's the three ways that we hold most of our cells together. Tight junctions that are usually there in large quantities, firmly holding two cells and preventing water's passage. Desmosomes hold cells together firmly but allow water passage between cells. And then gap junctions that don't quite so firmly hold together, but are helping to allow fluid flow from one cell to the next. Not between the cells, but from cytoplasm to cytoplasm. Alright, and what's left? Glands, okay. We bring up glands now because this is actually part of epithelial tissue. We said that most glands are pure epithelial tissue because they extend to surfaces. However, now we've got to modify that a little bit. There are some glands that don't go to, say, the surface of your skin or the surface of your stomach or the surface of your nasal membranes, but go to, as said, directly to the blood. We'll talk about that in just a bit. But a gland, cell or organ that secretes substances for use elsewhere in the body or release them for elimination in the body. Right? So the secretion that comes from a gland is usually a useful product. So, as examples, tears. Tears are useful. They help to lubricate your eye. Your sweat is useful because it helps to cool you down and even actually creates an acid mantle on the surface of your skin. But an excretion is a waste product. So your kidneys are excreting urine. Your digestive tract excretes, not fecal matter, because that's actually elimination. That stuff was never technically inside of you. It wasn't something made by your cells. It's stuff that you just didn't use when it passed through your digestive tract. But excretion came from your cells. And so bile is an excretion that comes from your breakdown of hemoglobin. But admittedly, you might argue, wait a second, isn't this secretion though? I mean, bile is useful to us? Yes, it is, but some of it's going to leave us having not been used, in which case we can say it's an excretion. But any waste is something that's there in excess to your body's needs. So it might be useful at some point, but if it's there in excess, now it's a waste. Nonetheless, all glands are going to be secreting or excreting products, right? And they're composed of epithelial tissue in a connective tissue framework and capsule. Right? So let's see, kinds, yeah, this one. Here's the first big distinction between two different gland types, exocrine and endocrine. Anything with exo means it's going outwards or outside. So exocrine glands secrete to an organ surface by way of a duct. There has to be a tube of some kind that leads to that organ surface. It could be an internal organ, like say to the inside of your stomach where you secrete stomach acid, or it could be an external one like your sweat or sebaceous glands. But as long as there's a duct of some kind, then you've got yourself an exocrine gland. Right? Endocrine glands go inwards. Now in this case, not to an internal chamber or space, but to the bloodstream. All endocrine glands have no duct, and they secrete hormones by definition. So if you have an endocrine gland, it's a hormone secretor. So it secretes hormones directly into the bloodstream, and then those hormones, these signaling chemicals, can now spread anywhere they want to in the body. So in a sort of semi-random fashion. So thyroid, adrenal, pituitary glands, all those are endocrine glands because they secrete hormones into the blood. But sweat glands and oil glands and mammary glands, they all secrete onto a surface, skin or otherwise, and those are going to be exocrine glands. Okay. So endocrine, exocrine. Right. Some glands are going to be individual cells. Say, for instance, like the goblet cells that we saw making mucus. Those are individual cellular glands. But some of them are going to be more multicellular structures, like a sweat gland would be. Right? Glands can also be classified by the nature of their secretions. Right? Serous, mucus, and cytogenic, mixed being a combination. All serous glands are going to be producing something that is thin and watery, so water is going to be the main component of it. So tears, milk, sweat, saliva. Well, actually, I shouldn't put saliva on the list. Tears, milk, and sweat absolutely are going to be thin and watery, and thus those are serous glands because they're producing a serum. Serum is another way of saying blood plasma without the proteins in it, which makes it more watery. Okay. Mucus glands, on the other hand, are going to be producing mucin, the protein, which then absorbs water to become the thick and sticky mucus. Right. Take note a little bit about the spelling here. If you have mucus, M-U-C-U-S, that's the noun. If you have M-U-C-O-U-S, it's not just because you're being British, that's because that's the adjective form. If something is mucus like this, then that means it is thick and it is sticky. Right? But if you're talking about mucus like this, you're talking about the actual substance that you could hold in your hand. Right? Now, cytogenic, these are glands that secrete whole cells. Cyto for cell, Genic, like genesis, creation, so they're cell-creating glands. In this case, the best examples are sperm and egg cells. So sperm cells are coming from what glands? Testes. Right? Egg cells are coming from the ovaries. So those two organs are considered to be cytogenic glands. Okay? So there we go. Two ways to describe glands based on where they secrete, exocrine and endocrine. 4 types of glands based on what they secrete. Sorry, no, 4. Three based on what they secrete, serous, mucous, and cytogenic. With mixed glands being ones that can do more than one form, like saliva. Saliva is both thin and watery in some cases, and thick and sticky in others. Depends on what it is that's going into the mouth. Right? And so your salivary glands are considered mixed because it can do 2 forms. But otherwise, you just think serous, mucous, and cytogenic glands. Okay? Then we can classify them based on how they secrete. Not where or what, but how. So modes of secretion. Merocrine glands versus holocrine glands. Okay. So, merocrine glands use exocytosis. The cell creates its product, packages it in a little plasma membrane bubble, a vesicle, and then brings that vesicle to the apical surface of the cell, and then the membrane joins with the vesicle, but the product is now spilled into the duct, or wherever it might go, and out onto the of the gland itself. But the cell can do this again and again and again, because it's just going through exocytosis in order to release that product. So a good example of this are our sweat glands. Our sweat glands do this all day long. But a holocrine gland, like an oil gland of the skin, requires that the cells die to do their job. Right? The cells, in this case, they don't package their product in vesicles. It accumulates inside the cytoplasm as inclusions. And then as those cells work their way to the top of the gland, or just the place where they're going to be expelled from, they burst. They undergo cytolysis and rupture, and now the substance that comes out of the gland is going to be a mix of the product made internally, but also cell fragments that are spreading outwards. So the entire cell disintegrates. When I was learning this one, I thought to myself, holocrine, okay, kind of sounds like Holocaust, where there was a lot of death involved. And yeah, that's also what we're looking at here. The cells die in order to release their product. Okay? So oil glands of scalp and glands of eyelids, there's some glands that are actually secreting an oily substance just behind your eyelashes, called tarsal glands. But yeah, both of those are examples of holocrine glands. And that actually explains something about oil glands. Say, for instance, the ones on your nose and your face. That's where you get blackheads. Those are oil glands which have had bacteria start to inhabit this space, this little opening into the gland interior. So it's essentially bacteria starting to inhabit this duct. And because the bacteria are there, they're feeding off of this cellular debris, which is actually pretty useful. I mean, it's proteins and phospholipids and water and so forth. They may not a lot of water, but still there's some, and triglycerides. And these bacteria, as they live on that stuff, they make their own waste product, and that waste product is what makes your blackhead darker colored. It's bacteria poop again. But this is one of the reasons one should wash one's face, so as to try and eliminate the quantity of bacteria that are there. But here's the thing, they like the oil. So if you've got oily skin, then you may have an increased probability of having acne, because the bacteria could now get a little bit deeper, they could start to multiply, and the body will respond with an immune reaction, causing the area to swell up and become red and start fighting those bacteria, and thus you develop yourself a nice pimple, okay, filled with pus. Right. But anyway, getting off topic. 2 forms for glands to secrete their products. You have the merocrine method, which is through exocytosis, and the holocrine method, which is through rupturing the cells, cytolysis. Alright, but there you go. That's how we're going to classify all of our various glands. Classified by how they secrete, where they secrete, exocrine, endocrine. Classified by what they secrete, serous, thin, watery secretions, mucus, thick, sticky secretions, or cytogenic, whole cells of secretions. And then we have the 2 methods of secretion: merocrine by exocytosis and holocrine by cytolysis. Okay, almost done. Membranes. A membrane, by definition, means it's a lining that helps to cover one surface and separate from another. So since we are talking about surfaces, most membranes are going to be epithelial tissue. Your cutaneous membrane is your skin, largest membrane in the entire body, and is lots of stratified squamous epithelium. A relatively dry layer that serves a very protective function for our body. It doesn't let stuff in and doesn't let a lot of water out. Okay? But we've got all kinds of other membranes. We've got mucous membranes, like you would find inside your nose and mouth and digestive tract. Right? We also have serous membranes. A serous membrane would produce what instead? A serous fluid, thin and watery. Right? So let's say digestive, respiratory, urinary, reproductive tracts, epithelium, absorptive, ciliated, and other types of cells, lamprey, areola, connective tissue, muscularis, mucosa. Right? This is describing the material that you find making up a membrane that helps to move mucus around. So in those tubes that we were just describing, those pathways, that's where pathogen could get in. So we need to put a mucous membrane in those areas to try to trap those pathogens and then move the mucus containing the pathogens out. So either sweeping up to the throat or having it pass out of the body along with the fluids that are going through the tubes. Okay? But serous membranes, which we call serosa, are usually lining internal surfaces that are not exposed to the outside environment at all. Like, for instance, the coat of membrane that's separating your lungs from your rib cage, that's a serous membrane. It produces a thin, slippery fluid so as to serve as a lubricant. Same thing for the surface of your heart, or the surface of your stomach, or your spleen, or your liver, where those things occasionally rub up against one another. Right? They produce a serous fluid that comes from blood plasma. It's meant to be a lubricating fluid. It covers organs and lines, walls of body cavities. Right? And then here's one more membrane. Whoops. A synovial membrane. Synovial joints are ones like the ones you have in your knuckles, your elbows, your knees, and numerous other places in the body. In fact, they're pretty much all the joints that can crack like that. That's because there is a little fluid pocket that lies between the bones in all of those joints. Right? And that fluid is a lubricant. It has a consistency, though, of egg white, so it's almost mucousy, but it's still meant to be a slippery fluid that is going to help to keep the bones from creating a lot of friction as they move against one another. So we find synovial membranes lining joint cavities. It's only a connective tissue layer and secretes this thick egg white-like synovial fluid. So 3 membrane types. You got mucous membranes. You got for making a sticky, thick mucus. You've got serous membranes producing something thin and watery and lubricant-like. And then you've got synovial membranes only found in joints, also for lubrication of those objects. And the rest of the chapter is really just one more thing, and it is about vocabulary. To describe how your tissues can grow in multiple forms as well as die. Right? So when you consider any tissue a collection of cells that all has a unified function, then there's 2 ways, basically, that you can get that tissue to grow. One is by increasing the number of cells in the tissue, which means the cells have to go through their own sets of mitotic division. Or you get the cells to grow bigger without dividing. And so that's these 2. Hyperplasia is tissue growth through cell multiplication. That's how you develop a callus. That is how your let's say fat cells are going to add to their mass, because you can have more cells. But hypertrophy is enlargement of pre-existing cells. Okay? Muscle growth through exercise is one example, and at the same time as it can also be hyperplasia, fat can also go through hypertrophy. Okay? What happens in that example? Let's use this thing for a better effect. So use this one. Okay, here we go. Let's use a little pencil function. Imagine that you start off with a cell, a fat cell like this, and you add you add triglycerides to it. So your fat cell is going to enlarge and becomes easily 5 times as big as it used to be. The internal space is loaded with extra triglycerides. Well, remember that whole bit about how if a cell gets bigger, it loses some of its metabolic efficiency? At some point, this fat cell is going to be triggered, be stimulated to divide in half. And then you end up with 2 smaller cells that will each be able to contain a certain amount of fat inside of it. Okay. But then these are going to grow again to a large size, and then they'll divide once more. So if the tissue is just growing because the cells are getting bigger, then that's your hypertrophy. But when it divides and the tissue gets larger as a result, then it's going through hyperplasia. So fat tissue can go through both. But muscle cells, not so much. Like neurons, once you reach your adult size, you have pretty much all the muscle cells you're ever going to have. But if you're bulking up and adding mass to your muscles, the individual muscle cells that you've got, oops, I'm trying to draw striations almost semi-successfully here. The single muscle cell that you've got is going to become fatter. Okay. So it didn't divide, it didn't turn to extra cells, they just got bigger. So muscle tissue goes through hypertrophy to enlarge itself, but doesn't go through hyperplasia. But your skin absolutely does go through hyperplasia. Skin is adding cells from the bottom layer to the top again and again and again to replace all the stuff that's flaking off of the surface. So hyperplasia, increasing number of cells. Hypertrophy, increasing the size of the cells. But in both cases, your tissue is going to grow larger. Okay? Then we have this term, a neoplasia. Anything with neo at the beginning means that you're talking about something new. So new growth, a tumor. In fact, the tumor can also be referred to as a neoplasm. And yeah, tumors they always have this bad reputation that they're going to be the thing that kills you, but we can have benign tumors or benign neoplasms which don't do you any harm. So an example of that would be a mole. If you got a mole anywhere on your body or just a particularly raised or thickened freckle, then you have had a neoplasia. You've technically had a tumor, but it didn't kill you. Right? Now, malignant tumor or malignant neoplasia, that's a bad thing because now that thing is probably growing and taking away nutrients from one of your other organs, or maybe it's growing so fast that it's actually putting pressure on something that shouldn't be squeezed, like your brain or various blood vessels or tissue in the heart, and so it's interfering with the function of the other organ. So that's the problem of having a malignant tumor. But all neoplasias are composed of abnormal, non-functional tissue. They're not helping you in any way. Even the benign one, it's not helping. It's not doing any harm, but still not helping. It's interesting to note that everybody that you meet has probably had more than one tumor in their lives already. But the wonderful thing about the human body is that it has this ability to stop neoplasias before they get out of control, either by killing the cells outright or just stopping their growth. So every one of us has defeated a technical cancer probably multiple times. It's just we tend to hear more about the cancers that people don't stop because they didn't get stopped, and so they're now doing harm to somebody. But still, anytime you've got that extra tissue that is not helpful, you've got a neoplasia. So that's all tissue growth. Then we have the part here on tissue development. Differentiation versus metaplasia. Differentiation means that you start off with cells that haven't been given a job yet. We typically call these things stem cells. These unspecialized tissues that you would find most likely in an embryo are now given a job once they are told to progress along a particular development line. So instead of using all those words, we just say differentiation. They become different from their original unspecialized form. So we all started off as one cell. Then we became 100 cells. Then we became this disk of a few thousands of cells. But at that point, we were still just a whole bunch of unspecialized cells in 3 layers. A mesoderm, endoderm, ectoderm. And then, from that point through the rest of our development to become an infant, we specialized those cells, and they went through differentiation. Even as adults, we still have cells that are stem cells that have to go through further differentiation, like in your bone marrow. Bone marrow produces all your blood cell types, all of them. And they start off with a stem cell called a hemocytoblast. Yeah, blood cell grower. And from the hemocytoblast, you then can develop white blood cells, red blood cells, and platelets, depending on which pathway they're triggered to follow. So in that case, as you go from the stem cell to the more mature cell, you're going through differentiation. Right? So, yeah, unspecialized becomes specialized. That's differentiation. Metaplasia, on the other hand, means that you're changing one mature tissue to another one. So it's already been given its instructions to become a tissue, but now it's either reverses those orders or gets a new set of orders. So this doesn't happen that often. The prefix meta means that there's a transformation. Plasia, a kind of growth. So transformation of one tissue to the next. So as an example, simple cuboidal tissue of the vagina before puberty transforms into stratified squamous after puberty. Right? So it's still epithelial tissue, but the shape changed. Pseudostratified columnar epithelium of the bronchi of smokers to stratified squamous epithelium. So there's another change. Another one that's a little bit more, let's see, well actually no, I should, don't want to make this lecture too long, so I'm going to stop this here. But still, metaplasia, one mature tissue turns into another one. Okay. Next one, tissue repair. We get hurt a lot, all right, and the place we're going to get hurt the most is what's closest to the environment, so that's our skin. And we see these two forms of repair happen fairly often. Regeneration, you replace dead or damaged cells with cells of the same type. So cut your skin, when it heals, you have skin cells there. The same skin cells, and hopefully in the same proportion. But sometimes a cut is really deep, or maybe a burn has removed whole sections of your epidermis. Well, then you may go through fibrosis instead, the replacement of damaged cells with scar tissue. Scar tissue has very few cells in it. It's mostly fibrous protein in a network mesh that is going to help to hold the other tissues together, but doesn't do the same job as the tissues that were there beforehand. So for instance, right here in my middle finger, I've got a scar that I got from a wood cutting accident when I was 13. I think it was 13. But anything is that I split the skin open, and I didn't get stitches just because it was in the middle of my knuckle, but instead I got some butterfly tape to put over it, and then was told to keep my hand immobilized for a long time. But I now have this, 1.5-inch long scar here, and if I poke a needle into it, nothing happens. I mean, I don't feel it. I can feel a little bit of pressure from the needle pushing into the tissue, but there's almost no pain until I push down past the damaged tissue. So there, I've gone through an awful lot of fibrosis. When you hear about somebody who has fibromyalgia, or what's another fibro one? Multiple sclerosis, no. Well, anything that's gone through fibrosis has gone through scarring. The liver can be scarred. If you have cirrhosis of the liver, that means that you've killed cells and have replaced it with protein fibers. So it's scarred. Right? So it does not restore normal function, unlike regeneration, where you do get normal function back, probably because you didn't have to replace the tissue with protein fibers only. Okay. All right, tissue repair. Okay, so we got growth. We have development, we have repair, and then here's the death part of it. Right? Atrophy, necrosis, and apoptosis. Right? You've probably heard of atrophy. If you have a person who is, say, bedridden for a long time, then their musculature is going to shrink. That's because of atrophy. Shrinkage of a tissue through loss in cell size or number. Right? All of us are going to get a little bit smaller with time. That's senile atrophy, through normal aging. We're going to get shorter because our intervertebral discs and our bones themselves will have less mass to them as we get older. But the person who is laid up in a hospital bed may now have disuse atrophy from lack of use. Now here it says, talking about astronauts. I think I mentioned before that some astronauts, when they come back down from being in zero gravity for 6 months at a time, have thinner bones because they're not pressing against gravity. They're not pushing against it, and so they had disuse atrophy there. A person who breaks their leg and has to be in the hospital bed for a couple months is going to have smaller musculature because they're not using it as much. So if you don't use it, you lose it. That is actually a truism when it comes to human anatomy, because of atrophy. So the tissue is getting smaller because you are either losing cells, so it's kind of like the reverse of hyperplasia, or the cells are actually shrinking, which would be the opposite of hypertrophy, so atrophy. Necrosis, however, is the form where tissue dies because something external killed it. Right? Premature pathological death due to trauma, toxins, or infections. So a burn, a cut, a crushing force, radiation, anything that kills your cells and makes your tissue smaller as a result, that's due to necrosis. Right? So when you hear about necrotic tissue, it's already dead, because that's what the prefix necro indicates, death. Right? There are certain kinds of necrosis that we've got listed here, like an infarction, sudden death of tissue when blood supply is cut off. So if you have a myocardial infarction, then you have the death of heart tissue, myocardial. Gangrene, tissue necrosis due to insufficient blood supply, not because the blood supply is cut off, but because it's gotten smaller, and so it's insufficient to get there. And then a decubitus ulcer is a bed sore or pressure sore, so that means that pressure had to be put on the skin for so long that it stopped blood flow, and thus you ended up with that kind of death of tissue. So reduces blood flow to an area, form dry gangrene, and gas gangrene is anaerobic bacterial infection. So there, bacteria got in, infected the tissue, and stopped the blood supply, and so as a result the tissue died around it. Right? But all of those still had to do with something external, outside of the body, leading to the death of the tissue. And here's the last one, apoptosis, programmed cell death. I mentioned this before when we were talking about autolysis and how lysosomes may lead to the death of your cells. Well, here's the instruction that tells you to do this. Our cells all have this programming in their DNA that says, now is the time to die. So it's a normal death of cells that have completed their function and best serve the body by dying and getting out of the way. The pieces that are left over, they then get eaten by macrophages and other cells, and billions of cells die by apoptosis thanks to their internal suicide program. Here it just tells a little bit about that program. There's a receptor protein in the plasma membrane called FAS. FAS activates enzymes, endonuclease chops up DNA, and protease destroys proteins. So basically those proteases and endonucleases, those are the things that came from your lysosomes to digest the organelles of the cell. But here's what you have to trigger in order to get that program to go underway. So the reason that we have billions of cells dying this way is because of things like getting sick. When you get sick, you make more white blood cells to fight the disease. But when the disease is gone, you don't need those white blood cells anymore. And so you tell them to die, they die, and they get cleaned up by your various macrophages. All right, so it's a decent list of vocabulary, but just keep in mind. We got two primary forms of growth: hyperplasia, multiply the number of cells; hypertrophy, make the cells bigger; neoplasia, you're creating something that is not useful. Okay. Development, differentiation, unspecialized cells become specialized; or metaplasia, a mature tissue changes to another tissue. Tissue repair, regeneration, replace damaged cells with the same cells; fibrosis, replace damaged cells with fibrous proteins and not living cells. And so you get scar tissue. Then there was the degeneration, death; atrophy, you don't use it, you lose it; necrosis, something external kills it; or apoptosis, you tell your own cells to die. And on that happy note, this video is over. So I'll put it up on Canvas. I hope it turns out to be helpful. Hope your day is going well.